With the lighting of this lamp, may darkness be replaced by light, ignorance by knowledge, and sorrow by happiness. Jai Maa Saraswati. Thank you very much, sir. Thank you very much, ma'am. Safa is an important part of rituals and celebration in Rajasthan, the state with rich culture, tradition, and its color. Safa is a symbol of honor and pride that is prominently witnessed among we Jodhpurites. It is a unique way of Jodhpur. And I would also invite Dr. S.N. Chawla sir कि वो औसेगी सर को साफा पहनाए और बुके प्रेजेंट करें.
वो किसमें डाली वो चेक करना है.
Thank you, sir. Next, I would invite Dr. Sharda Rane ma'am and Dr. Rajshri ma'am to please come forward on the stage. Thank you, ma'am. Now I would invite Dr. Anita Borges, ma'am, Dr. Rajni Joshi, ma'am, to please come forward on the stage. Gujral sir and Dr. B.L. Jain sir. Dr. B.L. Jain sir.
The two advantages hides my baldness also.
Dr. Tejendra Singh sir and Dr. D.R. Mathur sir. Thank you, sir. Dr. Asitva Mondal, sir, and Dr. Yogiraj Joshi, sir. Dr. Asitva Mondal, sir. Thank you, sir. Dr. Sandeep Mathur, sir, and Dr. Anurag Gupta, sir. Herbal ऊपर आ जाओ. Thank you, sir. Dr. Arpita Jindal, ma'am. Dr. Arpita Jindal, ma'am. Dr. Surbhi Tyagi, ma'am. Dr. Anjana Solanki, ma'am. Dr. Khatri, sir. Dr. K.K. Khatri, sir. Dr. K.K. Khatri, sir.
का पीछे क्यों लेके गए? ले जाओ आगे ले.
Dr. Surbhi Tyagi, ma'am. Dr. Anjana Solanki, ma'am. And Dr. Madhu Gupta, ma'am, please. Dr. Manju Raghav, ma'am. Thank you very much, all of you. Onwards, we proceed to our most awaited moment of the inaugural ceremony, the prestigious Lifetime Achievement Award. We are honored to present the Lifetime Achievement Award. Sorry sir, we noticed KC Agrawal sir is between us. Sir, please आप stage पे आइए. I would invite Dr. A.R. Kalla sir to please felicitate him with the Safa. Onwards, we proceed to our most awaited moment of the inaugural ceremony, the prestigious Lifetime Achievement Award. We are honored to present the Lifetime Achievement Award to our Dr. K.R. Joshi sir for his contribution in the field of pathology, microbiology, especially the mycology. Sir, your hard work, determination and passion have set a high standard of excellence for all of us. I now invite Dr. A.R. Kalla sir on the stage to say a few words about K.R. Joshi sir.
Hello. Good morning, all of you. It is very difficult task for all of us to summarize the academic contributions of Joshi sir in a single A4 size paper. However, we have tried our best to summarize. Sir K.R. Joshi sir has been a great teacher, a keen scientist, and a true human being with full of spirituality. He is a perfect living example of intelligence and diligence. He was born on 7th of December 1939 at Jodhpur. He did his BSc in 1958, MBBS in 1963, MSc in 1966, MD Path and Back in 1968 from Rajasthan University, Jaipur, and then PhD in 1975 from Auckland University, New Zealand. He is a member of many scientific societies. He has been interested in medical mycology, especially Candida and mycetoma. He has a long tenure of services from 1964 to 97, stepping up the ladder of promotions to the senior professor and head of department. He has also been additional principal of Government Medical College, Jodhpur and Ajmer, and a principal and controller of Medical College, Kota and Jodhpur. He has been examiner of MBBS, MSc, MD, PhD students at various prestigious universities of India and abroad. Dr. K.R. Joshi sir has received numerous national and international awards. He has organized many conferences, workshops and symposia. He has more than 100 national and international publications. Mycetoma and toxoplasma with well-known medical publishers. Dr. K.R. Joshi sir is the first to develop correlation of fixation techniques to demonstrate internal structure of Candida by transmission electron microscopy. He has been the first to develop a method of embedding intact colonies in epoxy resin for staining organization of colonies. The report of mycetoma by him in the middle ear cleft is the first to publish in the literature. The first case of histoplasmosis was detected and reported by him in Rajasthan. He was first to detect endemic focus of tropical leishmaniasis at Bikaner and existence of canine reservoir in India. He was first to report the use of coconut preparation in the treatment of parasitic infestations. We feel honored to felicitate such an intelligent, dedicated teacher, a doctor, a good human being, and a scientist with Lifetime Achievement Award in the RAJPATHCON 23. Thank you, sir.
अब मैं मंच पे बुलाना चाहूँगी आरसी पुरोहित सर को कि वे के.आर. जोशी सर का माल्यार्पण करें, उन्हें साफा पहनाएं, उन्हें शॉल अर्पण करें और प्रशस्ति पत्र। Thank you very much, sir. हमारे बीच डॉक्टर अरविंद माथुर सर हैं मैं प्लीज़ उनको स्टेज पे बुलाना चाहूँगी और डॉक्टर एन.एम. मेहता सर को बुलाना चाहूँगी. Sir, please come forward on the stage. So it's our honor. Thank you so much, sir. I would now like to invite Dr. RCPurohit sir to please come forward on the stage and say few words. For the
Thanks everybody. It's a very difficult thing to say anything because I'm not a good speaker. The only thing is, it has been a pleasure to organize this event. I'm just for the namesake, I'm an organizing secretary. The whole work has been done by all my associates. I'm just a figurehead, I just initiated it. I'm very grateful to Dr. Anita Borges, Dr. Gujral, Dr. Mathur, Dr. Mondal, Dr. Tejinder Singh ji for coming all the way from different places and gracing the occasion. And also other speakers. I'm especially thankful to Dr. Sharda Rane coming all the way from, because her presence was necessary being the national president of IIPM. I'm grateful to all the delegates who have come from faraway places, not only from Rajasthan, from Gujarat, Manipal, Madhya Pradesh, Gurgaon, and they have traveled all the way to be present in the conference. I now declare the academic part of the conference start. Thank you so much. My thanks especially to Dr. Kanchan Rathod, the most dynamic organizer of the conference, the best anchor we could get, and possibly the most beautiful lady in the whole group.
Thank you so much, sir. We now proceed to our scientific sessions filled with knowledge and inspiration. But first, I would like to invite Dr. Sharda Rane ma'am to please come forward on the stage and say a few words.
Dignitaries in this audience and renowned speakers and excellent stalwarts, Dr. Anita Borges Madam, Dr. Sumit Gujral, and speakers from all corners of the country, Dr. Mondal, Dr. Mathur, Dr. Tejinder Singh, senior faculties in the audience, various professors, young budding pathologists and postgraduates. A very good morning to all of you. It's my proud pleasure to be here today for this Rajasthan chapter conference, which is organized by the Jodhpur group of pathologists, Rajasthan chapter, as well as the SN Medical College, Jodhpur. So I'm very happy that you are having a conference nearly after 15 years that Rajasthan chapter is holding a chapter meet after 15 years. Though we had a national conference in 2016 at Jaipur, but I'm really very happy and very thankful to Dr. Purohit sir for taking this initiative and started this chapter again, which was defunct, and I hope this will continue for every year now in future. So that why this conference should have, because I think there are 15 years has passed away that whatever pathologists are produced by Rajasthan, they don't know how the association works, how our uses of our advantages of our association, and what the association do for all of us. So for that, I think I appeal to all the people who have passed last 15 years, those who are not members of a IAPM, please become a life member of a IAPM. There is our website, there is a iapm.org. The entire process is online. You can visit that website and become a member. And it is our all duty of our all faculty members of various medical colleges to motivate our postgraduates and young faculties to become a life member of a IAPM. And I am very happy that you are organizing this event once more, and thankful again once more. Thank you to Dr. Purohit, and I hope it will success definitely with, and all will reach with a academic experience. Thank you once again.
For our very first session, I would like to invite Dr. Sharda Rane ma'am. Ma'am is Professor and Head at PH Government Medical College, Baramati, Maharashtra, and presently she is the Honorable President of IAPM. In the past, ma'am was Honorable Vice President in 2022, Honorable Secretary, IAPM 2017 to 2019, Online IAPM Quiz Master 2013-2017, and ma'am's field of interest are histopathology, infectious pathology, renal pathology, general surgical pathology, dermopathology, and intraoperative consultations. This session would be chaired by Dr. Arpita Jindal ma'am, Senior Professor and Head, Pathology Department, SMS Medical College, Jaipur. Ma'am, please come forward on the stage. And Dr. Ajay Yadav ma'am, Senior Professor, Department Pathology, SMS Medical College. Please, ma'am.
Everyone, thank you for inviting me. Various dignitaries sitting on this hall, Dr. K.R. Joshi Sahab, Arvind Mathur Sahab, D.R. Mathur Sahab, Chawla Sahab, Dr. Madhu Gupta Agarwal Sahab, various delegates, eminent speakers, and renowned pathologists, not only of the Jodhpur but India, like from AIMS, etc. I come to know that this conference Jodhpur is organizing after a long time. So it's a very proud moment for the Jodhpur that we are organizing this academic feast. I hope this will be continued. In this conference, I am also alumni. My teachers are sitting. Most respected K.R. Joshi Sahab, undergraduate student. His age is just at par of my father. He was also born in 1938. He born in 1939, and is my teacher, mentor, anything you can say. Arvind Mathur Sahab, very senior, Mathur Sahab, N.M. Mehta Sahab, all our teachers. Dr. Madhu Gupta, HOD, is my classmate. So, it's very pleasant moment for me, and I hope those who have come from the various part of the Jodhpur country and Rajasthan, they will learn something from such esteemed teachers. You know the difference between a teacher and a student. Both are Manav, but teachers are Divya Manav. So here you will learn so many things from the Divya Manav like K.R. Joshi Sahabs and other senior pathologists, particularly young budding pathologists. I hope, and many congratulations, and it's my all best wishes to the organizing team that they will conduct a very nice academic feast. I will not take much time because this is an academic feast. We should not waste this time. Thank you.
Thank you so much, sir, for such inspiring and kind words. Now, I would like Sharda Rane ma'am to...
Yes.
Ma'am, please.
Okay. Now starting the academic activities, I invite Dr. Shada Rane to speak on the thyroid tumors, WHO classifications, and what is new about this classification, she is going to tell us. Dr. Shada Rane, please continue.
Hello. So, good morning, everybody. At the outset, I'd like to thank organizers and chairpersons for giving me this opportunity to speak and give an oration in a Rajasthan chapter. It's really honor to me. I really need a blessings from Dr. Joshi sir. He's the senior most pathologist in the audience. And I share with the same interest, that is infective pathology as a fungal parasite and all the infective lesions. So I am very happy to know that he is also he was interested in a fungal and mycology especially, and toxoplasma, and lot of inventions he has done. I also thank Dr. Vice Chancellor of Marwar University, and also thank organizers for welcoming this nice gesture, that is putting a safa, and I really enjoying that, and that's why I kept it since I am by birth Marwadi, so I like all these things. So that is the reason I kept this on my head, because I love to have all this, because every wedding we as a ladies also we do that in a Marwar, so you know that. So I really enjoyed this hospitality of these organizers since last night, and with these few words I'll start. Dr. Purohit has asked me, Madam, whatever topic you choose, you're welcome. So I thought this thyroid day-to-day practice everybody get, each practicing pathologist as well as in institute, where it is a small institute or a big institute. This is routinely we get the thyroid samples. And for years together, as a senior or a previous generation pathologist, we used to have only know how the thyroid tumors are divided: adenoma and carcinoma, papillary carcinoma, and the follicular carcinoma. But over the period of years, that is since 2017, there are a lot of changes which has occurred in a WHO classification of a thyroid. And last year recently we have a 2022 WHO classification. So I thought it is a nice platform to share what is happening in the thyroid tumors. Actually, I am from the BJ Medical College, Pune, undergraduate and postgraduate. So I spent my 40 years in BJ Medical College from 1980 to 2020, and from 2020 I have transferred to the Baramati Medical College, Government Medical College. It is called the Punya Shlok Ahilyabai Holkar Medical College, Government Medical College, Baramati. So this is my present college. I am heading the Department of Pathology, as well as I was a Deputy Dean till the last 4 months back, and now I am a purely head of the Department of Pathology. So coming to these thyroid tumors, we have, as I said, there was a traditional classification for ages. We have a benign tumors, that I will be talking mainly on the follicular neoplasm, because we are not possible to cover the entire classification, and major changes are in the follicular neoplasms. So we had the benign tumors, as I said, malignant carcinoma, well differentiated carcinoma, that is papillary carcinoma and follicular carcinoma, and we have a poorly differentiated and anaplastic carcinoma. So only these broad categories we used to know. But in 2017, there are a lot of modification has come, and this NIFTP and tumors of uncertain malignant potential, these two terminologies are introduced. and that is why that group is called borderline tumors. And rest are the same, but Hardal cell carcinoma, they have separated that entity totally. We used to say whenever there is a follicular adenoma with an oncocytic change, we used to call it as a follicular adenoma with oncocytic change. But now they have clearly defined the criteria when to call it an oncocytic adenoma and oncocytic carcinoma. Of course, carcinoma features are exactly they share with the follicular carcinoma. This WHO 2022 classification, there's a lot of changes have come. Up till now, the benign diseases, like we say multinodular goiter. So that is day in and day out we are getting in our lab. But now that group, they have put it into the benign neoplasm, that is under the umbrella of thyroid follicular nodular disease. This is something new. Why they have done it? Because this entire classification, they have done it on the molecular basis. And they have realized, because sometime we also face the problem, I think everybody of us face the problem, whether it is a adenomatous goiter, there is a dominant nodule in a multinodular goiter, but whether that is capsule is there or not, lot of problems we used to face and how to report. But now they have made the stringent criteria, and that is why they put this entity under the heading of thyroid follicular nodular disease. This was the change in a benign pattern, and instead of borderline, 2022 classification says they have divided into benign, low risk and malignant tumors. Low risk tumor, as in the 2017, that is non-invasive follicular thyroid neoplasm with a papillary-like nuclear features, that is NIFTP, and thyroid tumors of uncertain malignant potential, and hyalinizing trabecular tumor of the thyroid, because they say it doesn't behave like a follicular adenoma. That is why they have they have included into the low risk category. And malignant tumors, again they have introduced a new terminology, that is invasive encapsulated follicular variant of a papillary carcinoma. We know that NIFT, non-invasive follicular tumor with papillary-like nuclear feature, if that tumor shows the invasiveness of the capsule, like in a follicular adenoma and follicular carcinoma, capsular and vascular invasion, that is called invasive encapsulated follicular variant of papillary carcinoma. Why they have separated? Because the molecular signatures are different. All the follicular tumors, they have the RAS-like mutation, whereas the papillary tumors, they have a BRAF mutation V600E. So that is the reason they have put this terminology as a separate entity instead of putting into the papillary thyroid carcinoma. Then you have the oncocytic carcinoma of thyroid, and there is one more entity they have introduced, that is called follicular derived carcinoma, high grade type. Whatever carcinomas, follicular carcinomas we do encounter, they are usually follicular adenoma and with capsular vascular invasion or widely invasive, that is follicular carcinoma. They may not be the high grade, nuclear features may not be high grade, but that is why they have introduced this new terminology, that is follicular derived carcinoma, which is high grade, and in which they have introduced, that is differentiated high grade thyroid carcinoma. That means differentiated means they can show the follicular differentiation, they can show the papillary differentiation, but they will show the nuclear features will be high grade, and that is why they have put it as a separate entity. Then poorly differentiated carcinoma, as we know, it was there before and it will remain the same, which is showing the solid trabecular insular pattern, again with the nuclear features of showing high grade. That is why these two entities, they are put up into the one group, that is follicular carcinoma high grade type. And of course we have the anaplastic follicular cell derived thyroid carcinoma. This is just to complete the WHO 2022 classification. So this one more entity they have introduced, that is thyroid tumors of uncertain histogenesis, in which previously the sclerosing mucoepidermoid carcinoma with eosinophilia, this entity was under the heading of salivary gland type of carcinoma. But they have realized they are not showing the salivary gland type molecular signatures, but it is from the uncertain histogenesis. Then this cribriform type of modular thyroid carcinoma, this also they have put under the heading of uncertain histogenesis. Previously this cribriform type carcinoma they have included in a papillary thyroid carcinoma. But now when they have done all the even markers, IHC markers, they are not fulfilling the of papillary carcinoma or a thyroid origin, especially morules of these morular variant. Cribriform part, yes, they show the thyroglobulin, Paxate and TTF, but morules of this in between what you see, they are, that is why they have put under the heading of thyroid tumors of uncertain histogenesis. Rest everything is same. So what are the major revisions in classification and nomenclature of thyroid tumors? So this, we have compared this 2017 and 2022 classification. Henceforth, anywhere in any organ, wherever we used to report as oncocytic, never use the word, the Hurdle cell, but you should use the word oncocyte. It is across all the volumes of WHO. It's not only the thyroid. Then variant is terminology is replaced by subtype, because variant usually they use it for the genetic typing and not the subtyping. That is why, and again this feature is used across all the volumes of WHO for all organs. So we should use subtyping, subtype of papillary carcinoma, not the variant of a papillary carcinoma. This old pathologists like me, we are using this terminology variant, follicular variant of a papillary carcinoma. No, it is always you should use whatever it is subtype, not the variant. Then always use the mitotic count. So the number of mitotic counts, previously we used to always call mitosis per 10 high power field. But nowadays we should use it mitotic count, number of mitosis per square kilometer, 2 square kilometer, 2 millimeter, sorry. So 2 millimeter square. So why? Because everybody don't use the same types of, so you cannot validate that. Different types of microscope, different types of optics. So therefore we should use it, instead of using the per high power field, you should use it number of mitosis per 2 millimeter square. Actually approximately you try to do that, it comes to the same, but that is a correct entity, and the same this thing we can use for the digital whole slide imaging also. So that is the reason we should use this mitotic count. Then gene fusion, that is it is previously used to use that symbols, that is hyphen or forward slash, but nowadays that is for double colon, and that is again it is across all volumes of WHO. So these are some uniform changes they have made in all system. Coming to the thyroid, the thyroid follicular nodular disease, this is totally new entity which was not there in previous classification. Then follicular adenoma of with papillary architecture. This entity is they have separated from the follicular adenoma. In an old classification, if you all remember, we used to always say that with papillary configuration, follicular adenoma showing papillary pattern, but without nuclear features of papillary carcinoma. And that was not, that's why in 2017 that used to be called it as a variants of a follicular adenoma, whereas now it is a totally separate entity. Then sub-centimeter of NIFT tumors, oncocytic NIFTs and new subtypes of NIFT are come up within 2022 classification, whereas it was not there before. And previously invasive encapsulated follicular variant of PTC was their entity in 2017, but now it is this invasive encapsulated follicular variant of PTC. It is separated from other subtypes of PTC. Why it is separated? I will come in further. Then specific histologic typing, subtyping is needed. Whereas a papillary microcarcinoma variant, we used to call it in previously very occult type of papillary carcinoma with metastasis in a regional lymph node. That was very commonly we used to find. But that time we used to think that the prognosis of that is very excellent. But over the period of years, they have studied the various cases of these occult or microcarcinoma cases, and they have realized no, they still metastasize not in the local regional but distant metastasis also. Therefore, they said you should not separate as a microcarcinoma as a separate entity. It is just a specific histological subtype of a papillary carcinoma. Then Hurdle cell adenoma terminology is replaced by oncocytic adenoma of a thyroid, as well as Hurdle cell carcinoma of thyroid is replaced by oncocytic carcinoma of a thyroid. So these are the major revisions. Then this follicular derived carcinoma high grade, as I said, it is introduced in the 2022, it was not there in 2017. And differentiated high grade thyroid carcinoma, which was there before, that is differentiated means it can differentiate towards papillary, follicular as a oncocytic. So this was the same, but follicular derived high grade, it was not there in a high grade type. Cribriform morular variant, as I said, they have separated it from PTC, and we always encounter squamous cell carcinoma of a thyroid. Previously they said squamous cell carcinoma is a different type of a malignancy, but now they have said it is because of the squamous metaplasia, and it is a part of a subtype of a anaplastic carcinoma of a thyroid. And these embryonal tumors of the thyroid is to call it as a malignant teratoma, and now they are being renamed as a thyroblastoma. So these are the various major revisions. Then they have introduced the grading system for thyroid neoplasms. Example, especially 3 tumors, that is poorly differentiated carcinoma, differentiated high grade thyroid carcinoma, and medullary thyroid carcinoma. For the poorly differentiated and differentiated high grade thyroid carcinoma, they have used the 3 parameters, that is mitotic count, tumor necrosis, and Ki67 index. So mitotic count is more than 3 with presence of tumor necrosis, but Ki67 without Ki67 with convoluted nuclei, they call it as a PDTC, that is poorly differentiated, whereas more than 5 mitosis and presence of a tumor necrosis without convoluted nuclei, it is called differentiated high grade thyroid carcinoma. For medullary carcinoma, they have used Ki67 as an additional parameter along with the tumor necrosis and a mitotic count, which is they divided into high grade medullary carcinoma and low grade medullary carcinoma. Why we have to differentiate? Because the management depends on that, and clinicians should know what we are talking about. So we all, clinician and pathologist, should be on the same platform. So high grade tumors are always more than 5 mitosis, and low grade is less than 5 with less than 5% Ki67 index with absence of necrosis. Whereas high grade is presence of necrosis, more than 5% Ki67 and more than 5 mitosis. So this new grading system they have come up with in the WHO 2022 classification. Little bit elaborative on these things. I will take you on the little elaboration. That benign neoplasm, as I said, follicular nodular disease, follicular adenoma with a papillary architecture, and oncocytic adenoma. Though this is a newly introduced term, we all are aware of this is a multifocal hyperplastic neoplastic lesions occurring in the clinical setting of a multinodular goiter. It can be colloid nodule, it can be adenomatous, it can be adenomatoid, sometimes very difficult to differentiate. If it is there is a compressed surrounding stroma, appears as a capsule-like thing, then whether we are dealing with the adenoma or adenomatous nodule, goiter, we really many times we could not decide. They can be monoclonal as well as non-monoclonal. They are non-neoplastic, and the ICD code is not assigned to these things. So they are actually benign, but because we have they put it into this category, that is follicular nodular disease, because of this nature of these nodules. So these are the examples. This is how you see that how these nodules are seen here. You can see for the postgraduates, they are nodular. So these can be adenomatoid or adenomatoid nodules, and here well circumscribed as it's pseudo-condensation of a capsule, but they are not, it's just a multinodular goiter, but you have to say it is a follicular nodular disease. These are microscopy, they are varying sizes of follicles filled with colloid, but they are very well circumscribed and separated by the surrounding thyroid. Follicular adenoma, we all know this entity, it's a benign encapsulated mass which is solitary, which is a cold nodule, shows the uniform pattern of follicles, may be macrofollicular, microfollicular, they can be fetal, embryonal or trabecular. This is a follicular adenoma showing hemorrhages in the adenoma with surrounding normal thyroid, which is very well circumscribed, and nice capsule is, you can see all around, and see the capsule. So this is a small adenoma I have taken to show that it is surrounded all side by the thick capsule, and the microscopy shows again nicely capsulated microfollicular pattern, and the lower figure shows the follicular cell shows the oncocytic change. But this oncocytic change, if it is more than 75% of the cells are showing this oncocytic change, label it as an oncocytic adenoma. Otherwise, all the characteristic histolomorphological features are similar. This follicular adenoma with a papillary architecture, it is previously called as a papillary adenomatous or hyperplastic nodule. It is well demarcated, non-invasive, capsulated with intrafollicular papillary growth. Basically that is very characteristic, and these cells lined by these papillae are not showing the features of papillary thyroid carcinoma. They are often associated with autonomous hyperfunctioning of these thyroid and they appear as a hot nodule on the scan, and they have the molecular analysis shown as a TSHR, and that is the reason they have taken this as a separate entity. Maybe in future they will, after studying many such cases, they will come up with something else. So these are these typical thyroid follicles with the intrafollicular papillary formation, but you can make out they are very bland nuclei, basally located, they are not showing any features of papillary carcinoma. So you do see such things, but before that, young budding pathology, they are very enthusiastic. Once they see the papillae, they jump the diagnosis of a papillary carcinoma. So the papillary carcinoma is not you have to see the nuclear features of papillary carcinoma and not the only papillae formation. As I said, oncocytic adenoma is a distinct entity and require more than 75% of tumor cell to call it as oncocytic adenoma. And again, it is supported by specific genetic aberrations. So again, coming to the low risk group, that is NIFTP, and UMP, that is tumors of uncertain malignant potential, and hyalinizing trabecular tumor of thyroid. These are the three things they come under the low risk group. Coming to NIFTP, that is always an encapsulation. So then follicular growth pattern is there, but what are the criteria to call it NIFTP? Because 2017 only NIFTP come, now invasive encapsulated NIFT has come. So you have to be very sure to label any case as a NIFTP. There should not be any papillae, if at all less than 1% of the tumor. These tumors, they do not show psammoma bodies as against the, you see psammoma bodies in classical papillary thyroid carcinoma. Solid trabecular or insular pattern is always less than 30%. As you know that all these patterns are seen mainly in the poorly differentiated carcinoma. Then you have to have the nuclear changes of papillary carcinoma. And these, if you go through the recent Ackerman, that is 11th edition, the papillary carcinoma nuclear features also they are scored 0, 1, 2, 3. So if you show this score is more than 2 to 3, you have to see that that should be seen. There is no vascular or capsular invasion after extensive search at a tumor interface. This is very, very important. That is why before labeling to NIFTP, you should search extensively. The capsular section should be put more and more to search for the capsular and vascular invasion. If you see this, then you label that case as a invasive encapsulated thyroid carcinoma with papillary features. So that totally prognosis changes, there is a mutational characteristic changes. So that is the reason before giving to diagnosis of NIFTP, you have to be quite sure an extensive search of capsular invasion has to be done. There is always no tumor necrosis. There is no high mitotic activity, always mitosis will be less than 3, and there is a RAS-like molecular signature, and that is the reason that is separated from the papillary carcinoma. So these papillary, you have to remember, you have to see the papillary as well as the papillary-like nuclear feature to call it as a papillary, But if you see the follicular pattern, it may show the nuclear features of papillary, but it is not papillary because molecular signature is different. And that is the reason we divide these entity in a different group. You can get a sub-centimeter of a NIFTP like we get the microcarcinoma of a papillary carcinoma. Similarly, you can get the sub-centimeter lesions of NIFTP. But we have Asian countries, the incidence is very less as compared to the Western region. And the treatment for NIFTP is lobectomy with the clinical and radiological surveillance only. So you have to remember that, and that is the reason why that these entities are classified in a different groups. It's only lobectomy suffices. So this is a well circumscribed nodule, solitary nodule. It's looking like adenoma, but microscopically there is a follicular pattern, but you do see the nuclear features of papillary carcinoma, but there is no invasion. So it is a NIFTP. Then you have the tumors of the uncertain malignant potential. So what do you mean by that? They are defined as they are well differentiated thyroid tumors with a follicular architecture that are encapsulated or unencapsulated but very well circumscribed, in which invasion remains a questionable after thorough sampling and exhaustive examination. As all of us know, previously whenever a follicular adenoma we used to give the report, we do literally extensive search for the capsular and vascular. Ideally you should submit the entire capsule, that is the ideal way. But at least two-dimensional capsular sections we used to put to look for the, but these cases, so you have to, even if you do the after extensive search, you are not sure whether there is a capsular invasion, whether there is a vascular. Many times pseudo-vascular invasion we do see. Many times pseudo-capsular invasion you see. There is a breaking of capsule and you feel as if it has gone into the capsule. So this, if that invasion is questionable, those group you put it into the tumors of uncertain malignant potential. That is a purpose of this UMP. So these are two subtypes of these. There is either follicular tumor with uncertain malignant potential. It has naturally lacks the PTC-like nuclear features, and you have a well differentiated tumor of uncertain malignant potential where you have a pronounced nuclear features of PTC. So this group, it is again a vulnerable group, and you have to be certain to call it as whether the invasion is questionable. And these tumors of UMP are distinguished from a follicular adenoma and NIFTP by the presence of, as I said, questionable. Again, close follow-up is required in such cases as their biological potential is not certain. And this is how this chart from the Ackerman, it is very well explained that when to call it as a well differentiated tumor of uncertain malignant potential or follicular tumor of uncertain malignant potential. It is very well explained by this chart it is given in your standard textbook of Ackerman, which is the latest edition. Coming to the hyalinizing trabecular tumor, they have put this also entity into the low risk tumor. As they are well demarcated nodules with PTC-like nuclear features, but they have a trabecular architecture and they have the eosinophilic material in the intratabecular areas, and they have a MIB1 antibody at room temperature positive along with the all thyroid or follicular markers. And they have this, they lacks the both type of molecular mutations, that is RAS as well as BRAF, and that is why they separated this entity, and they have seen their prognosis is in between the follicular adenoma and a malignancy, and therefore they have put this entity into the low risk category. But here again lobectomy is a curative, but again a clinical follow-up is important. This is how the trabecular arrangement and syncytia of the cells which are palisading like nuclei in a thyroid. Think of this again, the eosinophilic material in between, that yellow bodies and all, but they are rarely seen in the tumors. Now coming to the malignant neoplasms, follicular thyroid carcinoma, we all know this invasive encapsulated follicular variant of a papillary thyroid carcinoma. This terminology is little confusing, but again and again when you see, you read, then your ideas get clear, and rest all are the same which I mentioned. But coming to the follicular thyroid carcinoma, Previously, we never used to say that criteria for diagnosis of a follicular thyroid carcinoma is the absence of nuclear features of papillary. But now it is mandatory. First, you have to look at the nuclei. Are they showing the papillary-like nuclei? Then, are they showing the follicular pattern or a papillary pattern? So that has come as a criteria for follicular thyroid carcinoma, that is absence of nuclear features of papillary carcinoma, well-formed follicles, to solid growth pattern, absence of Samoma bodies, and of course IHC showing the all thyroid markers, TTF, EMA, PAXET for a thyroid origin. And to differentiate it from invasive encapsulated follicular variant of papillary carcinoma, thyroid carcinoma and NIFT, you have to use additional these markers because these two entities have the different kind of molecular signature as compared to the other papillary carcinoma. Then RAS mutations are markers of follicular pattern tumors. As I said, these are the where they have the RAS type of mutation. Again, the follicular thyroid carcinoma, we know the minimally invasive, angio-invasive and widely invasive. The criteria are very well, everybody knows that. And here this is like you can see the mushroom-like capsular invasion of these tumors, whereas you can see the capsular vascular invasion is seen. So these are the criteria for, again here nicely you can see the breaking of this capsule, and usually the follicular carcinoma thyroid has a thick capsule as compared to the benign one, they have the thin capsule. We always have to think other way, but it is not like that. So also then you can see nicely invasion of a capsule in a thick capsule, whereas here you can appreciate the vascular invasion also. So this another entity I was discussing, it is an invasive encapsulated follicular variant of a PTC. It is a separate entity now, and no longer it is a subtype of a PTC. It is distinction from the follicular thyroid carcinoma is based entirely on a nuclear morphology, and it has a fibrous capsule, can invade the capsule and vessels. It has a RAS-like mutation, but it is not like a mutation of a papillary carcinoma. That is why this is grouped with a separate grouping, and treatment is minimally invasive tumors. They can be resected locally alone as they are low risk, but angio-invasive may require a completion thyroidectomy and adjuvant therapy to prevent a loco-regional recurrence and or to prevent the distant metastasis. And that is the reason we separate this entity and you further classify these entities. So here you can see this is nicely follicular pattern, capsulated tumor with the invasion, with nuclear features of these papillary thyroid carcinoma. So this is invasive encapsulated thyroid carcinoma with papillary-like features. So that is the reason it is separated. Coming to the papillary carcinoma, you know that until 2017, WHO classification of thyroid tumors, papillary thyroid carcinoma was exclusively diagnosed based on the characteristic nuclear morphology rather than the growth pattern and invasive features. But it changed with the introduction of NIFT. This definition is totally changed with the introduction of NIFT-P. In 2022, the papillary growth or invasion is added to the definition of PTC. And the molecular studies have shown that the encapsulated follicular pattern with the papillary nuclear features are a RAS-like, whereas BRAF V600 it is occurring in the PTC. These are the few cases of mine, that is papillary thyroid carcinoma, that there can be solid, cystic, there can be infiltrative, there can be encapsulated, solitary, multicentric. So this is another examples, and these are, you can see the various pictures of this along with the Samoma bodies with micropapillary pattern. These are cytological features, that is nuclear groove, intracytoplasmic inclusion, and you do catch sometime the Samoma bodies, that is concretions in even on the cytology. This is they are known to show the central area of fibrosis. This is a scar type of carcinoma, papillary carcinoma. So these are all types of these. This is a picture from the article from the WHO, that you can see the variety of the papillary carcinoma. You can have a conventional classical papillary carcinoma, then you can have a sclerotic with a lot of calcification, Samoma bodies, you can have a solid variant, you can have an oncocytic variant, you can have a tall columnar, you can have a columnar type, and you can have a hobnail variant. So all these are subtypes of the papillary carcinoma, but not the follicular variant. That one has to remember. Lower 3 one has the poorer prognosis as compared to the up to the 6 types of the papillary carcinoma. Coming to the malignant neoplasm, as I said, malignant neoplasm, you have a follicular thyroid, as you said, that is follicular derived carcinoma, this high grade, that is poorly differentiated, and differentiated high grade thyroid neoplasia. So there are diagnostic criteria for high grade thyroid carcinomas. They have depend on the Turin criteria we all know of the PDCC, but PDTC, and but this growth pattern in PDTC you have this solid trabecular or insular, that is STI we call it, or whereas differentiated you have a papillary follicular solid. Then the nuclear cytology, in a poorly differentiated there are no features of papillary thyroid carcinoma, whereas in differentiated, that is the reason we call it differentiated, because it may show follicular, it may show papillary nuclear features. And other features, as I have discussed about previously about the grading, that is tumor necrosis, mitosis and convoluted nuclei, that will be present in the PDTC, and one of the following will be present in the diffuse high grade. Whereas anaplastic features will be absent, that is the reason we have included these 2 categories under the high grade follicular carcinoma. So these are the poorly differentiated carcinoma. You can see the insular pattern, solid pattern, and grossly this solid tumor, and this is like here at times this comedo pattern also. Coming to the anaplastic thyroid carcinoma, there is not much change, but only thing, the primary squamous cell carcinoma of thyroid, which was listed separately in a 4th edition of WHO, but it is, they have done the multi-institutional studies and they reveal that 60% of squamous cell carcinoma, they carries a BRAF V600E mutation and express PACSET and TTF1, and prognosis is similar to anaplastic carcinoma. And therefore now this entity is under the histologic pattern of a anaplastic carcinoma. So these are the examples of anaplastic. You can see the sarcomatoid pattern, you can see the giant cell pattern, very angry looking, they are very hard, stony hard, grossly tumors. So then what is the prognostic classification of these follicular cell derived carcinomas? The histologic type, you have a PTC, you have a FTC, you have oncocytic. All these have a good differentiation. They have papillae or a follicle formation. They grade always low, and the prognosis is excellent. Whereas diffuse high grade, why they separated? Because they have a mitosis more than 5, and therefore prognosis is intermediate between excellent and dismal. And this PDTC, that is poorly differentiated, and anaplastic carcinoma, they of course have the poor prognosis because they have this histology pattern is undifferentiated type, and then solid insular and trabecular type with mitosis and necrosis. So all these features lead to the poorer prognosis. So because that stratification also we can do by doing by this classification also. Coming to the medullary carcinoma of thyroid, we all know this medullary carcinoma, medullary tumors, they arise from the C cells which are present in the thyroid follicles wall. And here many times in a normal thyroid also we do see the C cell hypoplasia here, which is seen here, and from there the tumors of medullary carcinoma thyroid arises. Grossly they can be, most of the time they are sporadic as well as the familial as a multi-MEN syndrome, and these tumors are huge and they show on the gross morphology that mahogany brown color many times, and these are the specimens from my collection, and you can see the tumor cells are separated by this eosinophilic material. These tumor cells are small, at times they show the eccentric nuclei, and the top figures are these H&E sections, whereas both the feature my photographs from lower side, they show they are the Congo red stain showing the amyloid material beautifully, which is nicely seen in this section. So these medullary thyroid carcinoma, they have in the 22 classification they have done the introduction of a grading, and these high grade MTCs have at least one of the following 3 features. They have a mitotic count more than 5, tumor necrosis, and Ki67 index more than 5%. This grading will help the high grade patients for close follow up, careful monitoring for distant metastasis, and histologic grade can be used as a data point in a clinical trials for the adjuvant therapy, since it is likely that adjuvant therapy will be the greatest benefit of this in such tumors. Coming to the thyroid carcinomas of salivary gland type with uncertain histogenesis, As I said, the salivary gland type includes the mucoepidermoid or secretory, and previously the sclerosing mucoepidermoid with eosinophilia was also included in the 17 classification, whereas now that is separated as a tumor, thyroid tumors of uncertain histogenesis in a new category, that is sclerosing mucoepidermoid carcinoma with a eosinophilia. Cribriform, coming to the cribriform morular variant of a carcinoma. This was classified as a subtype of a papillary thyroid carcinoma in a previous WHO because of its papillary pattern and the nuclear features of classical PTC. But now this is it has a different molecular profile than the PTC. The mutation there is present in this cribriform morular, that is mutation in the APC gene and the beta-catenin gene. And that is the reason these IHC, on the IHC they are negative for thyroid specific markers. These morules are negative for thyroid specific markers such as thyroglobulin peroxide, but positive for beta-catenin and ERPR. Therefore, this CMTC, that is cribriform morular thyroid carcinoma, is classified under the umbrella of thyroid tumors of uncertain histogenesis in WHO 2022. So here you can see, this is, I have not encountered this entity, but this is a book picture. You can see that this papillae, but in between the papillae you can see the morules, you can see the nuclear features of papillary, but these morules, they do not show the immunohistochemical markers of a thyroid, and that is the reason they have put it into the different histogenesis, that is tumors of uncertain histogenesis. So this is the main diagnostic group of the total WHO 2020 classification. In a nutshell, you can see that you have a malignant thyroid neoplasm, you have a follicular thyroid carcinoma, you have an invasive encapsulated follicular variant. In that again, you have a minimally invasive, you have an encapsulated angioinvasive and widely invasive, and you have an oncocytic carcinoma similarly, but you have a papillary carcinoma, there are subtypes of follicular, tall cell, corneal, solid, infiltrative. So infiltrative is again comes under the papillary thyroid carcinoma. So you have to understand the difference between invasive encapsulated and infiltrative papillary thyroid carcinoma. So infiltrative comes under the PTC because it has had the BRAF mutation, whereas the invasive encapsulated, it has got a RAS-like mutation, and you have of course the differentiated high grade, poorly differentiated and anaplastic carcinoma. So what is the takeaway for the clinicians? The clinicians and pathologists need to be aware of this new terminology and classification scheme, because what we are giving report, they should also understand what you mean by that when we sign out the report. The updated WHO classification will have a further impact on the upcoming clinical guidelines, cancer staging protocols, histology reporting standards and cytology reporting system. So this two-tiered grading system to distinguish high-grade cancers from well-differentiated follicular cell-derived carcinoma and medullary thyroid carcinoma. So this system has they have put up two-tiered. The overall prognosis of differentiated high-grade is similar to the poorly differentiated thyroid carcinoma. Patients with a differentiated high-grade thyroid carcinoma and high-grade medullary carcinoma require more intense treatment and should be more closely followed up for the recurrence. And the concept of low-risk neoplasm and histology-based grading system help guide personalized therapeutic decisions for patients at a different level of risk of these tumors. So the conclusion is molecular pathogenesis of thyroid tumors improved our understanding of a tumor origin and evolution of impacted their diagnostic criteria, and thyroid tumors are now classified based on the tumor cell of origin on molecular profile. So in nutshell, if you have, I realize there are a lot of confusion when there are various entities. So if you have this figure in front of you and you just say what you are saying, so first thing when the tumor comes, are there a PTC nuclei? Yes, then what will be your differential? If no, then how do you go further? See, this is this figure is very, very helpful when in a routine reporting. And if you want to base on the molecular criteria, then this figure helps you in coming to your final impression or final diagnosis. So thank you for patient listening, and I hope I tried to simplify a little bit what I understood that WHO 2022 classification. Thank you once again, organizers, for giving me this opportunity.
Thank you, ma'am.
Over to you, madam.
Hello. Thank you, ma'am, for such a wonderful overview of this 2022 and a couple of entities even I'm also not aware because I don't report too much of thyroid, but it was a wonderful overview about all the entities and the latest classification of thyroid neoplasm. I'm sure all the residents and juniors must have benefited with this, and also one thing I feel is very important is that pathologists should know how each and every entity is treated, because until unless we are aware of how they are treated, the reporting doesn't go the right way. So the small medical, the state medical colleges, not everywhere you have these tumor boards. And if you have these tumor boards where you come to know that how these entities, these patients are treated and what's the outcome, then I'm sure all the juniors are also benefited in knowing about the lesions and also how to go about reporting them. Thank you.
Any questions from audience? Ma'am, there is one question. Yes.
Hello, ma'am. Ma'am, some time back I got slides for review. It was reported as a NIFTP, but then I saw the criteria wasn't matching for NIFTP, so I reported as a papillary thyroid carcinoma encapsulated subtype. Now, this was before this 2022 classification,
Yes.
and that time lobectomy used to be the adequate for those kind of. But now you're saying that if there is invasion, we need to do molecular as well. Invasion is different, infiltrative different, and then total thyroidectomy needs to be done. So, should I talk to the surgeon to follow up on the case and treat it
Invasion
like
means it is again the minimally invasive, prognosis is good. So if it is minimally invasive, but it is better, I always tell my surgeon, even if you do one step further as a diagnostic level, it is always better rather than patient coming with the meds later on. Because we lost to the follow-up for this patient. Once they go, they never come back.
Okay.
But you should, NIFT, then invasive encapsulated it will be, if it is like
No,
that.
it wasn't NIFTP. It didn't met the criteria for NIFTP. It's a papillary carcinoma.
No, but then you should look for the invasion in
It
the
was there.
capsule.
Yeah, it was there.
So it is invasive encapsulated rather than a papillary carcinoma.
Okay.
Understood? That is the difference, and that is why they have separated, because they have studied and they have come with the molecular signal. Every institute we do not have a molecular. So you have to use that, extrapolate those findings and then you put it on your what you see on the histology.
But that was before this new
No,
classification.
in future I am saying.
Okay, okay. Thank you.
Any comments, ma'am?
All right, I think it's working. You know something, we don't make, or let me say this, decisions, management decisions are not made only on what we call something. Yes, of course it is made on the label that we give, but especially for thyroid disease, it is based on what are called risk criteria. Okay, and the risk assessment is based on, of course, the histology. It is based on the size of the tumor that is present in the thing. So now in your particular case, doctor, you had to, it's whether it was NIFTP with invasion or it was an invasive papillary carcinoma, it was the size of the lesion that would decide whether this patient had a lobectomy or a total thyroidectomy.
Hello?
Right, and you must know these risk criteria. They're very well established, you know, size, age of the patient, is it a woman or a man, and anyway nowadays woman and man is also disappeared from the scene. Is the patient above the age of 55 or less than the age of 55? So there are many different ways of deciding risk. Now what is the risk? This is what people don't understand. Risk of what? Risk of distant metastasis, not risk of local recurrence. Nobody is worried about local recurrence. Okay, it is about distant metastasis. And why do we need to do a total thyroidectomy? if their risk is of distant metastasis? And the answer is very simple, because if you do get a distant metastasis, you should not have the rest of the thyroid in situ, the other lobe of the thyroid in situ, because how do you treat a differentiated thyroid carcinoma? You treat it with radioiodine. So can you imagine the dose of radioiodine that you would have to give, because you have this very avid thyroid in situ, so it was like a sump. It will pull that radioiodine there. So when you first see the patient, you make an assessment of the risk of distant metastasis. Okay, it doesn't matter, carcinoma is not a reason for removing the other part of the thyroid. It is how likely is this carcinoma going to have distant metastasis. And please understand, I'm not talking about medullary carcinoma. I'm talking about what Dr. Rane was talking about, and that is those tumors, papillary and follicular, that are derived from the follicle. That means the thyroid follicle cells, not the C cells, okay? So we calculate, and we have criteria for calculating the risk. And what do we put it into? Low risk, intermediate risk, high risk. Okay, so if it is at low risk, you can leave the other part of the thyroid behind. You only need to do a lobectomy. Intermediate, you have to take a call. High risk, you must take off the this. And this is not about high grade. It is about high risk. And what is that risk of it, having a distant metastasis? And the reason is that when and if that distant metastasis comes, then you don't want the other part of the thyroid to be there in situ, because then you will have to go back at that time, take out that other part of the thyroid, and then give the radioiodine. Now you understood what the issue is. So no surgeon jumps to do a total thyroidectomy just because you have used a particular label or not. Okay? So now, since you're interested in it and you ask the question, go and look at risk assessment for thyroid cancer. Yeah?
Thank you, madam.
Thank you very much, ma'am. Now I would like to invite Arpita ma'am and Ajay Yadav ma'am to please felicitate our speaker, ma'am, Sharda Rane ma'am. Thank you, ma'am. Ma'am, please, you have to stay. I would now like to invite Dr. S.R. Negi sir. Dr. S.R. Negi sir to please come forward on the stage and felicitate our chairpersons. Thank you very much, ma'am. Thank you very much, sir.
I'll see you many times in Nigeria, because you are the only place I thought I remember you coming to conferences. That's me.
Heading for the next lecture, I would like to invite Dr. Sandeep Mathur, sir. Sir is a professor at Department of Pathology, AIIMS, New Delhi. Sir is known for his excellence in breast and gynec pathology and cytopathology. Over 250 publications in index journals, many ongoing research projects in areas of interest, founder member and secretary, Gynecological Pathology Society of India, founder secretary of the Delhi chapter of Indian Academy of Cytologists, fellow of International Academy of Cytology, and recipient of the AIMS Excellence Award for Research Photographs. Sir would be throwing light on endometrial pathology today, and this session will be chaired by Dr. RAJPurohit ma'am, Senior Professor and Head, IHPT Department, Dr. SN Medical College. Ma'am is also Superintendent, MG Hospital, Jodhpur. Ma'am, please come forward on the stage. And Dr. Purohit ma'am, Professor, Pathology at GCS Medical College, Ahmedabad. Ma'am, please come forward on the stage.
A very good morning to all of you, and it's indeed a great pleasure to be in this beautiful city of Jodhpur, and I really heartfelt thanks to the organizers, Dr. Purohit sir, Dr. Anurag, Dr. Mathur, Dr. Jain, and etc., and all the organizing team members here for having invited me, and it's really an august gathering here, and I feel delighted to be amongst all of you. So I was told to speak about endometrial cancer. So I thought I would like to talk more upon the emerging trends in the role of pathology in endometrial cancer management. Because after all, whatever we pathologists do has to translate into better patient management and care. So endometrial cancer is one cancer which has undergone a lot of recent changes in the way we report, in the way we convey to our clinicians about this cancer. So I thought it would be pertinent and nice to talk about the relevant things. Although most of the things as postgraduates we routinely learn. So this is the view from my office window, and really this is one of the better days in Delhi. Delhi currently is under a tremendous haze of pollution, as you all know, but yeah, this is the on the good days, air days, it looks like this. So the outline of my talk I would just give you a brief overview. I don't know why it's keep going on automatically going on to the next slide. Yeah. ये बार-बार अपने आप के लिए चला है, वो तो ठीक है, ये अपने आप आगे बढ़ेगा। Okay, so yeah, I'll be talking a bit about the overview of endometrial cancer, the risk stratification modules, what are the problems with pure histopathologic prognostication of endometrial cancer, and as you all know, on the recent last 10 or 11 years, there has been the evolution of genomic classification, and because of that, there have been some recent emerging trends. So finally, my lecture would kind of talk about the role of pathologists in integrating these advancements in day-to-day. Again, it's doing the same thing. So I think you should go into your. It's going rather fast, you know, for some peculiar reason. Slideshow, ma'am. Slideshow. Yeah. See what are the things on top. Play from, start. And just look at this log, it doesn't say that. Present view. And all the multiple slides. Yeah, ma'am. Sort of view. Now, so there are timings mentioned. No, I never put timings. So you may not have, but has it been? उससे क्या होगा, इसमें से चलेगा यहाँ से Yeah, it's still going on. I think now it won't do. Yeah, there was a play button which was going on. Okay, sorry for that little bit of technique. Hopefully it will not happen now. So, there you go. Maybe not now. So if you know the endometrium, it will be up. It's never happened before. इसमें कुछ सेकंड So, if you look at the endometrial cancer disease burden as such, it is one of the most common gynecological cancers in the developed countries, and the age standardized incidence rate is just about 8.4 per 1 lakh women. In India, as was estimated in 2018, the total number of estimated new cases is 13,328 with 5,000 deaths. And the age standardized incidence rate in India was 2.3 per 1 lakh women, mainly attributed to changing in the lifestyles and the reproductive profile of women, especially in urban areas. And the majority of the cases they present after the 50s, although we are now if you look at this particular figure here, if you look at just compare the incidence in Delhi and Mumbai, if you see that corpus uterine cancer was way down in the till the late 90s. And it has undergone, just like some of the other cancers, it has climbed up the ladder, and now it ranks at number 5 amongst all cancers in most of the cities in the country. So there has been definitely, and all of us in practice have also witnessed reciprocal increase. So if you see world over, in the developed world, it is the 4th most common cancer in women, and whereas in the US it ranks the top amongst the female genital tract cancers. And there has been, as compared to say I would talk like about lung cancer, the amount of research and amount of advancements regarding therapy, etc., have not kept pace so well with the endometrial cancer as has been with lung cancer, etc. And there is this is the kind of the estimated deaths which was predicted in 2018. So there are 12,558. So it's going to be a major problem. But the only good thing about it is that most of them would be early endometrial cancers, early stage endometrial cancers, and thereby having and endometrioid being the most common variety, it's kind of there is a better outcome in most of the patients. So you have, if you study the profile of the endometrial cancer, most of the disease is localized or regional at most, and distant metastasis is very uncommon in this thing. So I put up this slide to say that is endometrial hyperplasia or carcinoma self-inflicted disease. Now these are the risk factors which are pointed out here for obesity, and obesity, as we know, has a definite link. And what has obesity got to do with? It has got to do with two things: change in our lifestyle. So we have moved on from a very active lifestyle that we used to have as children to now what is a very, very sedentary lifestyle. The work is such that it makes us kind of glued to the chair or the desk. And of course the changing dietary habits, as you would see the current generation, the kind of food which we eat mostly. So that has also undergone a lot of change, and I definitely, studies also, scientific studies also agree, and I believe this is one of the major reasons why we are seeing so much of endometrial hyperplasias and carcinomas these days, even among young women. And this is reflected here in the risk factors if you look at. So estrogen was a known, prolonged exposure to estrogen in any way was known to be a risk factor for both endometrial and also to a certain extent for breast cancer. And the demographic profile, with increasing age there was increasing risk. Now family history of uterine malignancy, that's particularly Lynch syndrome, tremendously increases the relative risk of having an endometrial cancer. So it is one of the indications for a risk reducing surgery. And associated medical, you know, the famous triad of uterine cancer, the corpus cancer syndrome, diabetes, hypertension and obesity. And a lot of focus have been nowadays on these obesity as a, and of course those patients of other cancers receiving prior pelvic radiotherapy has also an increased risk, and so are breast cancer patients receiving tamoxifen. So they are the relative risk described for each of these entities. And I would like to particularly focus on the obesity link, and why it is important is if you see this, that estrogen production occurs by conversion of androgens to estrogens by adipocytes, and the more an obese an individual is, more likely that has happened, likely to happen. Then obesity associated hyperglycemia and insulin resistance leads to abnormal IGF-1, which leads to signaling activation of mTOR pathway and increased cell proliferation. There is associated inflammatory and oxidative stress, alteration in cytokines, steroid hormones, adipokine pathophysiology, and also some cellular and vascular perturbations which occur in obese individuals. There are a lot of studies in this regard if you will go through them. Now, leaving aside the risk factor, if you go to the genetics of it, this is well established now. We know that the classical, the traditional type 1 and type 2 classifications are associated with a different set of genes. Like the type 2 or the high risk cancers, they are mostly the P53 abnormal variety is the most common genetic mutation. So P53 mutation, they are defined by that, and along with that the other mutations may also occur. So I have highlighted some of the common mutations in each of these types of cancers. So PIK3CA mutation, beta-catenin, all these mutations, they are more common in type 1 cancers. So this is the traditional endometrial carcinogenesis pathway if you look at. So there is a type 1 pathway and the type 2 pathway. Type 2 pathway is defined by the P53 along with other mutations like HER2 mutation has also been found to occur in these kind of cases. Now there was a lot of risk stratification modules mostly described by the clinical societies, particularly the radiotherapy society associations. They have tried to come up with many and evaluated many of these risk stratification modules. So we were also talking in context of thyroid about risk stratification that is so relevant for endometrial cancers as well. So these risk stratification modules, as you can see over here, they are mostly focusing on histologic parameters as such. So just there was this article, just how accurate are these major risk stratification system for early stage endometrial cancer. So there was this study which evaluated all these modules and found at that time that this ESMO modified classifiers emerged as the highest predictive power of, or discriminatory power of risk prediction. But since they are based mainly on morphology, there are problems with morphologic assessments because they are bound to be subjective. There is always a poor diagnostic reproducibility amongst pathologists who are less exposed or who are seeing more cases. There will always be that disagreement, inter-observer disagreement regarding grading especially. And there have been studies which have shown only moderate agreement in the grade. Of course, now they have come up with better guidelines. Agreement between the grade given on endometrial aspirate vis-a-vis the final hysterectomy specimen is also limited. Since they use the risk predictive models, they use mostly pathological parameters, there is always a risk of under or over treatment. So we need better subtype specific approach and need for incorporation of what we have learned from the TCGA data about the molecular features into both classification and risk determination, so that we can better assess the biological behavior and improve the treatment decisions and thereby the outcome. You are all aware about this, has been there for a long time now. So most of us know about these. So what this TCGA did was that it classified endometrial cancer into 4 major subgroups: the polymutated MMR deficient, non-specific molecular profile, and P53 abnormal. So this is, I'm sure most of you are very well versed with this, so I won't go into the details of this. And our recent advances understanding is what I've already talked about: the metabolic syndrome, obesity, dietary habits, etc., and exposure to estrogen. Then the incorporation of molecular classification. We have good surrogate biomarkers now for these molecular classes, as well as some of the risk predictive biomarkers. We have better screening tools for hereditary genetic syndromes like Lynch-Cowden syndrome, and the conservative management of early stage endometrial cancers because of this late ages at marriages, etc. So we are seeing a lot of situations where we need to manage hyperplasias and early or well-differentiated early stage well-differentiated endometrioid carcinomas with hormonal therapy. These are day-to-day cases which we will encounter more and more often now. And of course the role of sentinel biopsy, ultra-staging, and there are many newer targets which are emerging for. So if you know, besides the color change in the cover page of the WHO classification, there's been a lot of changes inside also, particularly in regard to. So I'll quickly go through, although my talk is more on endometrial cancer, but I cannot do without talking about endometrial hyperplasia. So you know that now we have got a 2-tiered grading system, and the reason for that we have to more focus upon detection of atypical hyperplasias because they progress at a faster rate, and higher percentage of atypical carcinomas progress to carcinoma endometrium. So I'll kind of give around 10 or 11 roles which us pathologists need to incorporate while we are dealing with hyperplasias or carcinomas. So one is identifying atypical hyperplasias. Hyperplastic curettings are usually very bulky in nature, and this is how a hyperplasia without atypia would look like, or we call it as a benign endometrial hyperplasias. The glands are well delineated, they are classical cigar shaped, elongated nuclei, not very prominent nucleoli, etc. And there is no more severe crowding of glands. So these are all examples of benign endometrial hyperplasia. You can look at the nuclear features. So I won't be going into very deep histological details because that will be a lecture by itself. And then you can also have endometrial polyps with endometrial hyperplasias occurring in them. And this is the more significant one which I talked. This is considered clonal in nature and associated with the genetic abnormalities for development into carcinoma. So these are atypical hyperplasias which by nature show a greater degree of glandular back-to-back glands. And the nuclei may be rounded, there may be prominence of nucleoli. So these are atypical hyperplasias, but you need to differentiate them from endometrial carcinomas. So whenever you see a maze-like or a labyrinthine pattern, fusion of glands, cribriforming occurring within the glands, or viloglandular, very prominent viloglandular architecture, solid areas of neoplastic cells, or a stromal desmoplastic response, those should be like these shown in these images. Those should take you away from. So endometrial cancer is one cancer which can be diagnosed even on curating. Invasion is not a criteria for diagnosing endometrial. So these features which I have highlighted here in this slide, these are enough to label even on a biopsy where you don't see any myometria. And a good way to do that, whether it's a hyperplasia or a carcinoma, is to draw an imaginary line along the glands. If you are able to delineate all the glands from one another, that is not likely to be a carcinoma. You can see squamous morules even in endometrial hyperplasia, so should not, squamous morules is one misconception. People think when you see you should call it a carcinoma. That's not the case. These are all examples of atypical hyperplasia. So the question is, our clinicians often ask, are there any biomarkers which can help you in that? So there has been a lot of articles if you see, and these are very favorite thesis topics also for students. Even I have done one thesis of one of my students many years ago. So we did these 4 markers, P10, ND, RG1, KRAS and beta-catenin, and we did find that as compared to a proliferative endometrium, there was reduced expression of KRAS, then there was beta-catenin was, nuclear translocation was occurring, but not in all cases, in some cases. So they are not very good sensitivity as such beta-catenin has. NDRG1 was one marker which we studied, and we found one interesting finding was that the membranous positivity became more enhanced as you progressed from a proliferative to an endometrial carcinoma as compared to an hyperplasia. P10 is, of course, now we all know that it is lost, and that was also a finding in our case. So these are some of the things which people have done, but none of them have stood test of time. PAX2 is one of the newer emerging markers which people are using. But so now, so that was about the endometrial hyperplasia, which I think we should know if we are dealing with an endometrial carcinoma, because we need to separate them from endometrial cancers and also recognize atypical forms of endometrial hyperplasia. So cancer, the classical Bachmann classification, type 1 and type 2 has now been replaced by this in the latest WHO. So you have clear-cut endometrioid adenocarcinomas have been classified according to molecular subtypes. And then you have the high-risk variants, which are these serous, clear cell, undifferentiated carcinomas, mixed carcinomas, and mesonephric-like, etc., etc. So these are all high-risk carcinomas. So it's important to be aware about the morphologic features and this. So another change which has very recently come up is the FIGO staging W 2023. So there have been many advances in the understanding of, based on the understanding of the pathologic and the molecular features, that FIGO has now incorporated them. What they did was they used the ESGO-ESTRO as European Society of Pathology guidelines as a template for adding new classifications to the proposed molecular and histological scheme. So what this does is it incorporates the morphological as well as the recent advances in our understanding regarding the. So I've highlighted some words. So this is the next two slides which show this classification. What I've highlighted is the words which have been newly introduced. So they have introduced this word non-aggressive histologic subtypes, terms like focal or substantial lymphovascular invasion, low-grade endometrial carcinomas limited to both uterus and ovaries. So I'll be going to the details of these in the subsequent slides. Cervical stromal invasion has been better defined than I already talked about LVSI. And then they have used the term aggressive histologic subtypes. So all these, they help in staging a disease. Then stage 3 has been defined according to the ovarian involvement. So for example, if you have a high-grade tumor which is involving the, it is automatically stage 3. But a low-grade tumor involving the ovary can still be stage 1. So that's why it's kind of a very different kind of a staging system, which is we all as pathologists have to be aware about. So our second role is to histologically type and grade, because both have a bearing on the final staging and thereby the risk prediction. So you have to say aggressive versus non-aggressive. So non-aggressive histological types are the low grade. So low grade, grade 1 and 2 have been clubbed. So now it's a two-tiered grading system. So low grade is grade 1 and 2 and high grade is grade 3 endometrioid carcinomas. But there is a caveat there: when the molecular subtype is poly, that can still be a stage 1 tumor. Then you have the serous, clear cell, mixed, undifferentiated. These are mesonephric-like, and gastrointestinal type mucinous carcinoma. These are all the high risk or aggressive variants. So this is the classical type 1 tumors. As we know, the endometrioid adenocarcinomas, estrogen related, they may have macrosatellite instability, they may have P10, KRAS, etc. mutation. This is the classical picture of an endometrioid adenocarcinoma, and you see this same feature. So generally in most of them are grade 1 or grade 2 tumors. They are well-formed glands, and many of them don't differ drastically from a nuclei of a proliferative endometrium or at best endometrial hyperplasias. They express ER, PR, Vimentin. P53 is usually wild type. Strong ER, PR expression or patchy can be seen. And what is currently now being extensively used is the IHC for these MSI markers. So MLH1, PMS2, MSS2. You can see in this slide that all of them are retained. Even if they are focally present, you consider them as retained, because they need not be strong and diffuse like a P53 abnormal kind of a criteria. You don't use for that. So this is a typical grade 1 endometrioid adenocarcinomas, which is showing. So tumor grading can be done on the biopsy. It can be done on the final specimen. it has more impact on the endometrioid variant of endometrial carcinoma and the NSMP, the non-specific molecular profile. And high grade are defined by the histologic entities, which I'll be coming to later. And the ISGIP guidelines have recommended confluent microanecylar pattern as confluent growth. So sometimes you may be seeing this problem when you see glands, but they are so small that at low power it gives a solid kind of an appearance. So such cases should be, there is always a dilemma what to call them, whether you should consider them as grade 1 or you should consider them as grade 3. So you can upgrade by 1, that's what the ISGIP guidelines say, but they mention it very briefly in one sentence, so I don't know how much to rely on that. And MMR and polydifferentiated mutated tumors may appear high grade due to frequent mutations. So this is a typical grade 1 endometrioid adenocarcinoma. This would be a grade 2 kind of an endometrioid adenocarcinoma. So you are well versed with the grading, and this is more to do with that microacinar pattern which I was talking about. Now whenever there is a diffuse atypia of this kind of a nature which is present throughout, not a focal or a patchy diffuse atypia, you are allowed to upgrade by 1. So a grade 1 will become grade 2, or maybe a grade 2 will become a grade 3 based upon this. So, but it has to be present in majority of the cells, more than 50% to upgrade it. And grade 3, they are more than 50% is the solid area, so you will see a lot of these kind of solid areas. You may get these days a lot of benign endometrial hyperplasias treated with progesterone, as I told you. Many of them, they are desirous of fertility, so you will see this what we call as the pill changes or the exogenous hormone induced changes. And nowadays even some of our we have patients who are grade 1 endometrioid who are being treated because they are desirous of fertility. So the another challenge which has come for us pathologists is to assess response to progesterone therapy. So there have been some articles which have kind of given guidelines on how you report them, like for negative for residual hyperplasia with treatment effects, atypical hyperplasias with treatment effects, and whether the patient, more important is that I feel this kind of a classification which says, clearly defines whether it's a resolution, a regression, a persistence, or a progression, or it's a recurrence. That means it has initially responded but again recurred. So these are more objective kind of definitions of response which the clinician will understand better, especially when a patient is young and she's undergo these. Another role is, very important role is the depth of invasion, LVSI and cervical stromal. As I told you in the staging system, these are all important. So few tips about the depths of invasion. Regarding depth of, you have to measure the myometrial invasion as well as a percentage of overall myometrial thickness. It should be corroborated with the microscopy sections finally, because gross can sometimes be deceptive. LVSI should not be included in assessment of myometrial invasion depth, because you may have deep LVSI, but that's not the actual depth of invasion. And if more than 50%, then it upstages to 1B, provided it is non-aggressive and there are no LVSI. So that's the implication of the staging. LVSI is always assessed at the invasive front of the tumors. The mimickers are of course retraction artifacts, and the microcystic elongated leaf-like pattern, which is very associated with aggressive type of endometrial carcinoma. So that you have to exclude when you are considering something as an LVSI. And substantial LVSI is defined as more than 5 vessels which are involved, whereas focal or anything less than that is focal, and if none, then it is no LVSI. So this is subject to sampling. You should ideally take 1 section per centimeters of the largest tumor diameter, because the more sampling you do, the more likely are you to pick up these LVSI. And regarding cervical stromal invasion, it should be at a level deeper than the benign endocervical glandular crypt. So you should consider it as a cervical. Any kind of superficial spread of cancer is not considered as cervical stromal invasion. These are some pictures of focal and substantial LVSI, and this is the microcystic elongated gland which I was talking about, or sometimes a fibromyxoid stromal reaction around a gland which may mimic such tumors. The fourth role is to document adnexal, tubal or lymph nodal involvement. So implications only I'll be talking about here. So in case of high grade, I told you if there is any adnexal involvement, it is considered always metastasis. But there is now in the FIGO 2023 what they have told is if there is a low grade endometrial adenocarcinoma without other risk factors like extensive LVSI or more than 50% myometrial invasion, then it can be considered as stage 1A3 only if there is the ovarian involvement is unilateral and the uterine characteristics are less than 50% focal alveoli and there is no other metastasis anywhere else. So that is the implication of this. So in the stage 1 now you see there is a 1A3, so they are both considered as independent primaries. That means there is an endometrioid carcinoma arising in the ovary as well as the uterus, which will behave as low grade, thereby they can be treated as separate entities, hence they are included in stage 1. And lymph node, the thing which we are also doing now in our institute is the ultra staging of sentinel lymph nodes, although we are not doing in all cases, but sometimes we are asked to do this, so that is something you will be aware of. So I will take you through some cases. Case was a 54-year-old woman with bleeding, and she had a diagnosis of endometrioid grade 3 carcinoma on a biopsy. Now you can see the endomyometrial interface, you can see mostly a solid looking tumor with some areas of patchy areas of necrosis. There are some gland formations as well, but the dominant part of it is solid in nature. The cells are quite pleomorphic in nature. Then at places they have this metaplastic like look. You can see they have more abundant eosinophilic cytoplasm, prominent nucleoli. And look at the marker profile there. ER is also variable. In the better differentiated areas it is showing ER positivity. P53 is appearing mutated in the high grade looking areas, solid areas, whereas it may be a little wildish looking in the other areas, but it was definitely more than 80% in this case. Then P10 is lost, BRG1 is retained, CK and EMA were diffusely positive. Although I have not shown a picture, this is very important because it helps us make a diagnosis of a high grade endometrioid carcinoma and not something else. This is another completely solid looking tumor with very few glands. You can see this is ER, pan-CK diffusely. So this is why am I showing a pan-CK slide here, is because when you need to differentiate an undifferentiated carcinoma from a grade 3 endometrioid, pan-CK is helpful. In endometrioid high grade, it will be diffusely positive, where it will be patchy, focal, dot-like in case of undifferentiated carcinoma. P53, as you can see, despite the high grade, is wild type. So high grade endometrioid adenocarcinoma is an important entity. It's not a waste basket. Just based upon the solid areas, it's not. This has been now identified as the subtype which shows the maximum heterogeneity in the molecular profile. So you can have high grade with polymutation. So this is one cancer, and it's endometrioid high grade. You have to subject it to polymutation testing, because this is the kind of carcinoma which patient can benefit by de-escalation of therapy. Okay. And if it is P53 mutated, I showed you one wild type P53 case of high grade also. So then it has a poor outcome. Many of them fall into the non-specific molecular profile. Now here most of them have an intermediate or good kind of prognosis, but the caveat is that if they are ER negative, then they have a poor outcome. So even amongst the high grade endometrioid which are PR, that's why the importance of ER staining in them. Now this is a 65-year-old woman. You can see not a very enlarged uterus. It's commensurate with the age, but also a very papillary kind of a tumor with long, predominantly papillary and glandular architecture. The nuclear features are very high grade. Now these are distinctive nuclear features which when you see, you should suspect a serous carcinoma. And you can do a P53 which will be positive in more than 80%. P16 can help you. Sometimes it will also be diffusely positive. WT1 may or may not be positive. If it is positive, it is usually focal and not so strong as you see in serous carcinomas of the ovary. One must be wary of an endometrioid carcinoma. So whenever you see gland forming tumor, don't jump to a diagnosis of endometrioid carcinoma, I would say. If you see very high grade looking nuclear features in a tumor which is showing predominantly gland formation, it is not automatically a high grade endometrioid or something. It is likely to be a serous carcinomas. Therefore we have to do P53 immunostaining, and these are the classical type 2 tumors. This is well known. So these kind of P53 abnormal tumors have now gone into the copy number high, which we classify in the molecular classifications. Now the importance of this is they can sometimes occur in younger women, whereby you should check for germline BRCA mutations, TP53 or CHEK2 mutations, or a personal history of breast or ovarian cancers. In the US and amongst the African American women, this is the type which is fairly common, and is also associated with pelvic radiation and tamoxifen use. So I have already told you some of the morphological features which help you differentiate between a high grade endometrioid versus serous. And now with the molecular classification, this has in some ways helped us stratify them better, because both of them do not have a similar outcome as was we previously thought of. And so nuclear are generally not diffusely markedly atypical in high-grade endometrioid carcinomas. I told you can do a CK, ERPR, you can even do a PAC-SATE, EMA, all those things can help you. E-cadherin can also help you differentiate. So sometimes all this, and then the intraepithelial carcinoma is which is limited to the mucosa or the glands, but even such tumors, whether they are in the polyp or on the surface of the endometrial surface, they can metastasize. So one cannot label them as intraepithelial in the true sense of the word. So it is important to differentiate high-grade endometrial. So this is one of the roles of a pathologist which we have to play. I'll show you a lung mass biopsy in a 58-year-old male. There was a gland-forming tumor, very well-formed glands. This patient was a known case of endometrial carcinoma many years ago. We did an MSI panel on the lung biopsy, and what do you see? That MLH1 and PSMA are retained, MSH2 is retained, but MSH6 is completely lost. P53 is wild type, PR is positive. So this is a typical scenario of a MSI hypermutated tumor. They have a high mutation rate and other traditional mutations which occur in endometrioid carcinomas also. So you all know about microsatellite instability. They are because of mismatched repair genes, and they may be associated with germline mutations like inherited cancers like Lynch syndrome, and or they may be acquired somatic mutations in the current cancers. So Lynch syndrome you are all aware about. In the context of colon cancer also it is important, and there are various guidelines of this thing. But regarding endometrial cancers, that morphology which should make you suspect is tumor infiltrating lymphocytes, peritumoral Crohn-like infiltrate, undifferentiated tumor, origin in the lower uterine segments, and concurrent ovarian cancers. This should make you suspect. So this is a typical Crohn-like infiltrate which you see, and that should, which you also see in polymutated cancers, can be seen in this MMR deficient. So there are clear-cut guidelines which you can follow, and kind of. So MSH2, MSH6, they go together, and MLH1 and PMS2. Of course, if you get a promoter only MLH1 loss, it may be due to promoter hypermethylation. Thereby, you have to do hypermethylation testing. A loss of MSH6 is always considered. So you can have all sorts of possibilities which are there. So generally, defective MLH1 alone is 90% of the time it's a sporadic loss, whereas MSH2 alone or MSH6 alone is more often associated with germline mutation, and null pattern is extremely rare. So you must be aware about all these patterns and the interpretation of the MSI. So I told you even a focal positivity in the tumor nuclei in some areas is considered retained or intact, and it is not considered loss. This is an example where the MLH1 and PMS2 are both lost. We did one study in our institute based upon the MMR status of endometrial cancers, and we found kind of MMR or MSI lost in 36 of our cases. So the important thing is that when you are dealing with a specimen of a Lynch cancer patient or a risk-reducing surgery in the context of endometrial cancer, one must do extensive sampling. In fact, the entire endometrial should be submitted in totality. And what you find people have found in prophylactic hysterectomies and risk-reducing surgeries have been atypical hyperplasias, small focus of low-grade endometrioid carcinomas. So this emphasizes the need that we need to. So we need to apply appropriate IHC panel for surrogate molecular classification. This is another role which we have to play more often. This is a tumor, one of our cases showing solid-looking tumor, dense lymphocytic infiltrate around. You can see the tumor cells having fairly abundant cytoplasm. So this is the kind of morphology which you will see in a poly-ultramutated tumor. Now the beauty of this is that it has a favorable outcome even with this kind of a high-grade morphology, and they may or may not associated with MMR deficiency, and there are certain hotspots which have now been clearly identified. So by Sanger sequencing and all, it's not a very expensive test no longer to do. You can get it done less than 10,000 rupees. So you can do this test either by sequencing or by the NGS or by Sanger sequencing. So that's there's no as yet IHC marker for polymutation testings. So what it can do is it can help us in de-escalating therapy. and there is this paradox of excellent survival outcome despite the high-grade morphology which these tumors have. And there are other features also which these tumors can have besides the lymphocytes. They can have a lot of bizarre nuclei in between, then this eosinophilic cytoplasm is associated with bizarre nuclei, and of course the lymphocytic infiltrate. So we will be now more and more often asked to do polymutation testing in our, and it is something which I think we will have better techniques and simpler techniques to perform this. And the figo-endometrial cancer staging can also be done. So the relevance as of now for the molecular classification is for stage 1 and stage 2. For example, a stage 1 polymutated endometrial cancer, even if it is high grade, it will be, you can de-escalate therapy in that, provided it is not, this is how you have to report it. You have to call it stage 1A, M small stands for molecular, and whatever mutation testing you have done is written as a subscript to that. And stage 2C molecular, whenever there is a P53 abnormality by molecular analysis or IHC, you will classify it into stage 2 even if it is otherwise early stage. So FIGO stage has now completely incorporated this molecular classification. What they have told is they have even recommended that you do it as far as possible in all these stages, even where it is not relevant as of now, even for the stage 3, stage 4, and report it so that we can build a database of knowledge regarding the molecular abnormalities. Now here is a tumor which is showing gland formation as well as solid areas. The cells appear relatively monomorphic. If you see here, the glandular part is also showing high grade nuclei, and these are, if you look at the ER, it is expressed in some areas where it is diffusely lost. Wherever there is gland formation especially, it is showing. The BRG1 is intact, although its expression is also variable. You can see it is quite dim and weak focal in some of the areas. The P53 in the gland forming areas, it is kind of wild. Here it is showing P16 as well as P53 abnormal subtypes. Now look at the CK. The CK is completely lost in these areas, and you can see them only in the gland. So is the Paxate also lost. So Paxate would normally be positive in a high grade. So such kind of tumors are de-differentiated endometrioid adenocarcinomas. You can also get them as completely solid looking tumors of monomorphic cells. You can see CK is only focal positive here, ER is lost, P53 is diffuse, Vimentin positive, CD10 is not there, BRG1 is retained. So these kind of cancers are clubbed, undifferentiated and de-differentiated carcinomas clubbed together, and they frequently involve the lower uterine segments, and they unlike high-grade endometrioid adenocarcinomas, they are more often consisting of discohesive monotonous medium to large cells. They show the IHC profile as I've shown in the pictures earlier. They may also express neuroendocrine markers, by the way. So they are relatively uncommon. About half of them would show MMR loss. They can be associated with Lynch syndrome. And when MMR deficiency along with this kind of a tumor is present, it's a predictor of response to PD. So you can do PDL1 testing in these tumors. This is something again which is an emerging thing in this context. And you can of course do INI1, BRG1 testing, SMARCA4. These are special subtypes of undifferentiated carcinomas which show these kind of specific mutations. So recognizing undifferentiated carcinoma and differentiating it from a high-grade endometrioid adenocarcinoma is also an important thing. And these are the things, just for the sake of completion, this is a case which showed this classical hobnailing of nuclei. You can see there is MCR positivity, which is cytoplasmic and granular in nature. CD15 can also sometimes be positive. And these are clear cell. These are also type 2 or aggressive by diagnosis. Therefore, it's important to diagnose them. And there are all sorts of markers which are available. MMR expression is intact in most of these patients. ERPR can most likely negative. P53 can be variable. So P53 can be a defining marker in this. There is a heterogeneity of molecular, all 4 molecular subtypes can be seen in this. And the ones which are P53 abnormal clear cells are still higher, more aggressive. As it is, they are aggressive, but you can have. So this is another tumor which is showing. So they have an impact on management, that you need to know whether what kind of aggressive variant it is and the associated molecular abnormality. Now this is another carcinoma. Look at this. This was a 56-year-old female. They're showing well-formed glands infiltrating deeply into the myometrium. Everywhere you don't see any solid areas. There is some eosinophilic secretions present. You can see over here in this at the top, middle. And these are ER-PR negative despite such well-differentiated glands. P53 is wild type. P16 is also supporting the P53 wild type. TTF1 is focally positive. CD10 is positive. GATA3 is positive in quite a significant amount. WT1 is negative. So what kind of a carcinoma is this? This is a mesonephric-like carcinoma. This is important to recognize this because it is associated with aggressive behavior. And these are the markers which will be positive: Paxate, GATA3, TTF1, luminal CD10. So they are deeply infiltrating tumors and have propensity for metastasis as well. This was a large polypoidal mass. This is a typical appearance of a carcinosarcoma. Whenever in an elderly lady you see a predominantly luminal polypoidal exophytic large mass, you should think of a carcinosarcoma. So it is now considered more related to carcinoma rather than sarcoma. So you actually don't need to do any IHC markers in such cases. It's more of a morphological diagnosis, and it can have all sorts of molecular alterations within them, including P53 abnormalities. And the survival depends on the stage. Higher the stage, more dismal is the outcome. And compared with high-grade endometrial carcinomas, they are having more frequent lung metastasis. These are some examples where we did some IHCs. Some people consider desmin as a prognostic factor. The higher the expression of desmin, the poorer is the outcome. So you can see sometimes they show stromal sarcomatous differentiation, heterologous elements, etc. can be seen in the form of cartilage, bone, etc. Here you see this cartilage, and heterologous element is considered. So you have to recognize all these rare aggressive subtypes of endometrial carcinomas. That's very important. And there is a good panel. This just table will not be going through it in details, but I've already shown most of these, that these are the markers which you can do and try and segregate these high-grade carcinomas or aggressive carcinomas. And all the other things which don't fit into either of these, they are now clubbed into the non-specific molecular profile. So they are the non-polymutated, non-copy number high, and non-MMR deficient. So there have been in the early days there have been a lot of this Leiden classifier was there, and this is a Vancouver group which gave this classifier, and now we have fairly sorted out this testing, and most people recommend that you start with polymutation testing, and then you do MMR profiling, and then finally P53. So you get ultimately, by using most of the, except for poly, the others are all IHC based surrogate markers. So you can have a molecular classification. So I've already told you the significance of or implication of molecular classification, its impact on the stage and its impact on the prognosis. But one must be aware that now there are endometrial carcinomas with multiple classifiers. So there are studies which are going on, and some of them have come up with some results that, for example, patients with both poly and P53 should be considered polymutant. So earlier we would think that if there was just a P53 abnormality, we would treat them as serous carcinomas, but no longer is the case. So there are multiple dual classifiers, triple classifiers which are emerging nowadays, and we need to know a little bit more about them as the years go by. And this is the risk grouping as we was being discussed in the context of thyroid. This is the ESGO-ESTRO-ESMO risk grouping, in which they have called these terms like low risk, intermediate risk, high intermediate risk, high risk, and advanced metastatic. So your clinicians will treat based upon all the parameters which you give in your report, and there are various criteria for inclusion in the high and high intermediate risk. They are well given in journal articles, you can go through them. Finally, I'd like to mention some of the other predictive and prognostic biomarkers. HER2/neu testing in serous carcinomas is now being recommended because it gives an L1-CAM is a predictor of outcome, of worse outcome amongst tumors with P53 wild type or non-specific molecular profile. There have been 2 risk trials which have studied the significance of adding an immune checkpoint inhibitors. So this Ruby trial and the Keynote trial, they are going on, which are predictive response to it. So you have to now you will be now as pathologists asked to do PD-L1 testing as well in endometrial cancers besides HER2/neu testing in serous. And there is also an emergent look, just like for ovarian cancers, homologous recombinant DNA testing. So that is also because it gives you a target for PARP inhibitors. Circulating metabolites, there's a long list if you go through the articles of circulating metabolites ranging from serum ferritin levels, etc. So all those things are also being used for prognosticating endometrial cancer. Circulating tumor DNA and cell-free DNA is another thing which will be used in the years to come to follow up these patients. So there are a lot of these targets based on which there are targeted therapies which are hypothesized, and some of them are even in advanced stages of their trials. So risk stratification and identifying newer targets for guiding therapy is another role we will play. And finally, this ultra staging of sentinel lymph nodes. This is something which your gynecologists will be doing, especially in early stage endometrial cancers. They will be sending these lymph nodes, which you will take a section of a HNE section and a unstained section, followed by 50 microns of wasting of tissues, and again taking a section. So basically what you are doing is you are deep sectioning or serially sectioning your lymph nodes, sentinel lymph nodes, and staining them with pan-cytokeratin stain to pick up isolated tumor cells or micrometastasis. So as of now, isolated tumor cells do not have any significance, just like in breast as well as in endometrial cancer. So ultra staging of sentinel lymph nodes is something which we will be doing. And this is the pathology data sets which you will be required to report, and most of these I have talked about today. Okay, and some of them are purely morphological, some of them require molecular tests, but the whole idea is that you should have accurate definition of what you use as a criteria for a particular thing. For example, what will you call as a grade 2, what will you call as a grade 3, what will you call as a more than 50% invasion, what will you call as a substantial LVSI, and of course the accurate histologic typing. All these things need to be standardized, and it should be reported accurately. So histological segregation into type 1 and type 2 endometrial is no longer adequate. You need a molecular classification which is feasible. It's not as if only the advanced centers can do it, and it provides objective reproducible categorization of endometrial cancers, aids in the risk stratifications, and as I told, they can now be achieved at a lower cost. So this gives a kind of a better management for the patient, and with changing lifestyles, hyperplasias and carcinomas are on the rise, and pathologists will encounter challenging scenarios in endometrial biopsies as well as resection specimens, and it's important for all of us to be updated with the new inputs expected from them while evaluating carcinomas and resections. Familiarity with all the surrogate biomarkers which we are using is very important. We should not misinterpret them. So everything in the world began with a yes. One molecule said yes to another molecule and life was born. So was this thing. So I'll thank the organizers for having invited me today, and I hope yes ma'am.
Thank you, sir, for such a nice lecture. You have definitely showed changes which has been occurred in endometrial biopsy totally. Its targeted therapy and its more de-differentiated forms. Thank you once again, sir.
Thank you very much. There's a question.
Question from audience.
Thank you, sir. So thank you for enlightening us on endometrial biopsy so thoroughly. So I just want to ask you a basic question that sometimes we receive the endometrial biopsies with the histopathological features of endometrial hyperplasia with or without atypia, most of the time without atypia, in the normally thickened endometrium, that is most of the time within 5 mm. So how do we report these cases without the immunohistochemistry profiling, or should we advise the IHC profile in such cases? So just want to ask how to report these cases.
Yeah. It's a very good question. So yes, you can see, after all, what you see under the microscope is considered the gold standard. So I would say that IHC markers or molecular profiling you should not even think of doing, because it will not help you in this situation. So you should go on the basis of your thorough evaluation of that biopsy, Now, one or two caveats I'd like to say here. Many people call hyperplasia based upon, sometimes the stroma is not there in between the glands. So whenever you're calling something as a hyperplasia, always look whether the architecture of that part of the endometrium which has come in the biopsy is intact. So you get fragmented biopsies. Sometimes these patients have withdrawal of progesterone and thereby breakdown of the endometrium.
Sir, in the hysterectomy specimens.
Hysterectomy specimens, if you see a hyperplasia, you call it a benign endometrial hyperplasia, irrespective of whether the endometrium was thickened or not.
Okay.
But you have to have your guidelines clear that you differentiate it from a secretory or a proliferative endometrium or an interval endometrium, because that, as you all know, secretory endometrium is also crowded. Many people misinterpret
Yes,
that
sir.
as
Yes, sir, definitely. Even infiltration of the stroma.
So that interpretation, as long as it's correct, we should, I think it's our duty to report even if it's a hysterectomy specimen. But I find more often people wrongly report on the biopsies where there is a stromal breakdown and the artifactual crowding of glands. That should not be considered as hyperplasia.
Thank you, sir.
How do you deal with, you've got a carcinoma in the endometrium and you've also got a lot of adenomyosis, okay? And sometimes the adenomyosis also shows the carcinoma, okay? So how do you then estimate depth of invasion?
Correct. So, ma'am, actually, in that case, I at least, whatever, I have seen some of these cases which you are talking about, and so I'm currently even having a case which I have just finalized the report where I believe that the carcinoma has arisen in an adenomyotic focus because the way the tumor is, it's forming very grade 1 tumor looking tumor, but it is in the depth. So there was probably multifocal adenomyosis within which this arose. Now in this particular case which I am talking about, it was easy because the tumor had reached the serosa and it was not the mesonephric like or anything which did those markers, etc. But yes, this particular I would go by for the depth, ma'am, I would go by the original, the greatest tumor dimension which was there, the original endometrium. I'm assuming that you're saying that there was also a carcinoma which was arising from the endometrium.
Yeah, obviously. I mean, if
And
there is a carcinoma,
which was in the adenomyotic focus.
yes.
Yes.
What I...
But I would also like to know your views on this.
Well, what I tend to do is that, to see, just like you said, what is the depth of invasion of the original tumor, and most of the time they are superficial. Yeah. But I also like to see the endometrial stroma still preserved in the adenomyotic foci. If I don't see the endometrial stroma still preserved in the adenomyotic foci, then I tend to consider that as being, within the myometrium, because that's another focus of carcinoma, which is independent, and it is going to be in the myometrium. It's a difficult problem, so I just thought that I would ask you how you deal with
it. I agree
it.
with you, and there are no clear-cut guidelines in the societies, guidelines, etc. They're not existing.
Yeah.
There's no clarity on this. But I would, ma'am, logically thinking, I would not consider that as a deep invasion, even if the adenomyotic.
No, I agree, but I think it depends on individual cases. I thought the second thing that I think is worth talking about also in this audience, because we're getting a lot of women with this metabolic syndrome. They are obese, many of them have PCOD, etc. So they have an endometrium that is constantly being stimulated by estrogen it's unopposed estrogen because there is no progesterone over there. And they have very, very hyperplastic as well as very odd looking endometrium, almost like EINs that are completely involving the endometrium. So what do you report them on when you have got, because all of these are youngish women, they probably have late marriages, they come for infertility, they are 30, 32, 33. And if I saw that endometrium in a 60-year-old, I would have called it a carcinoma, without hesitating. But now, I am seeing a lot of patients who are being referred because somebody has called it an endometrial carcinoma, grade 1. So how do you deal with that problem?
Yes, so whenever we see any hyperplasia in a young woman, and let me tell you, we are seeing a lot of these nowadays, as we used to see them in the past, as opposed to what you saw them in the past. And we call them on the basis of what we see, ma'am. If we are like the criteria I mentioned, if they're not meeting the criteria of a carcinoma, there is no fusion of glands, there is no other features which would kind of make me suspect a low grade. Of course, on that biopsy sample, I would report it as either a benign or atypical hyperplasia. Carcinomas, I usually don't report them in these young infantile. What I usually do, I pick up my phone, call up the concerned clinician and inform them that this is what this lady had and this represents only a part of her endometrium. I don't know what is the rest of the endometrium going to show. What she definitely has to go for is a progesterone therapy to deal with that, and there should be a follow-up biopsies on that. At least a 6-monthly or a 3-monthly biopsy needs to be done to know whether it is either regressing. If it is not regressing, that is also a worrisome feature according to me, and the patient itself and the clinician, they have to discuss and take a call on that.
Well, sometimes, you are reporting much of your stuff that comes from a hospital. Okay, your hospital, you can pick up and talk to the patient. It's always good to talk to a clinician, whether he's in your hospital or outside of the hospital. But I think it is useful to, report something as a function of what that endometrium is actually receiving as not physiological, but stimuli, endocrine stimuli. And that's why I always call these, an endometrium that is showing the effects or long-term effects of unopposed estrogen. That is what I say, and then I can always put a caveat, because if the woman is young, okay, and this is true also of a woman who is older, if she has a low-grade endometrium, it is unopposed estrogen, maybe coming from her fat. So I like to say that, and then give whatever caveat that I like to say, because
stimulate the clinician to
it
investigate
stimulates the woman. And I usually, if it's a little older woman, I write a little, sort of asterisk, and I say, look for the source of this estrogen, because sometimes it's coming from the fat, sometimes it's coming from the diet, sometimes it's coming from HRT, which one doesn't even know.
Usually, if you look at the source or the cause of these hyperplasias, they are unmodifiable most of the times. The factors
it depends. It depends on what. In young women, you can modify it without any problem, and if progesterone doesn't work, gonadotrophins, either agonists or
modification by therapy, ma'am.
Therapy, yes. Yes, not by losing weight. No.
PCOD, how will you treat a PCOD?
No, you'll have to do it with. Yeah, of course. It is modified
so
by
in that sense,
hormonal.
It doesn't help much, but yes, of course, that's why I say, if you are in your context, maybe you're not able to call them up, but when
I do them all the time, and I write whatever I talk to them in the report. It's always good to do that, because the patient goes to that clinician but may not be treated by that person, then goes to another one and another one, because many of these patients require infertility treatment. But in general, I recommend to all my students, etc., don't look at an endometrium or any target organ of, for that matter, whether it's the breast or the endometrium or whatever. Look at it from the point of view of what is stimulating that growth. And I even, say people want to date endometriums and all. I think that's gone. It's all gone. Nobody should be dating endometrium. But look at an endometrium and see what has acted on it, and how it has modified this endometrium. And it is so enlightening. That's what I am saying. Look at target organs from whatever it is that is stimulating it. Thank you so much. I enjoyed your talk very much.
Thank you. Thank you.
Thank you very much, sir. Thank you very much, ma'am. Now I would like, ma'am, please come forward and present memento to Sandeep, sir. Now I would like to invite Dr. Nirupama Kothari ma'am, Senior Consultant Pathologist, Sterling Accurus Lab, to please present memento to our chairpersons. Thank you very much, ma'am. Now we will be having a short tea break of 10 minutes. So please come back quickly because we are running out of time. It's in the corridor only. Tea. Hello. Tea break. After tea break, we will have Dr. Tejendra Singh sir's class. So please come back quickly.